So I got a question for you, Corey. What if in the world of addiction and recovery, we did a better job of tracking patient outcomes? So what I mean by that is right now there is a lot of kind of scattered information in that there's been some attempts to kind of put all the data together. And there's been some longitudinal studies where they follow people into a treatment center and then out on the other end. And I've seen ones that go for as long as 5 years. But a common theme to some of these, not all of these, is that the only outcome variables, that the only thing that they're actually tracking is whether or not drug use has stopped and the person is abstinent or not. That's kind of as simple as it is for some of the treatment centers. Then some of the newer studies, you're seeing some more kind of complex tracking where they're actually measuring variables like they get a baseline of drug usage. Say a person's using this much cocaine per week, and then they follow him or her down the line and see if that metric drops like they want it to do.
Yeah. But
with all this stuff, I see an awful lot of, it looks to me like there's many studies that are kind of, for one thing, there'll be blatant conflicts of interest. So it'll be a study done by the Association of Treatment Centers on the effectiveness of treatment centers. So obviously, whatever that study determines can't be taken quite as seriously as a study that didn't have a conflict of interest like that.
No.
And I don't see a lot of well-funded, well-conducted studies in this area. But, I think you probably had the same experience. Maybe your experience was a little bit better, but when I was an intake patient and when I was assessed, the goal, I really wasn't asked about what I wanted out of treatment. I was just told that I had a problem and this was what was going to fix it. And by fix it, they mean we're going to stop you from using any kind of mood altering substances for the rest of your life. So if we adjusted that, I think, based on what we know about treating people as individuals, that seems to have an effect, right? If we were able to design treatment programs based on the information that we got through these processes, then maybe things would go better. I don't know. What do you think?
Yeah, I agree with you. I wonder, what would we need to measure? What would the actual factors be that someone on our side would want measured? So, for me, quality of life would look like social engagement. It would look like some sort of a sense of balance. It would look like that I'm, not just meeting the basic needs of my daily living and paying my bills, but that I have a sense that I'm like thriving and flourishing within the things that I want to do and need to do.
Yeah. So
some of those things are hard to measure.
Exactly. I think you're talking about subjective measures, which are definitely harder to track in this case than objective measures. Objective measures can be as simple as, is the person still alive?
Yeah. Or has the person gone back to work in a healthy, productive way? For those of us who are off work. Well, as anyone who's listened to my episode or other episodes that we've done and talked about, there are so many factors that can play a role in that for individuals. Things that change what the outcome of a employment look like or the career trajectory. But I think it's a good question to imagine asking the people on our side of it. And I think I was asked that question. I was just trying to recall if I was asked that when I was completed sort of the intake part. We're not talking about the the part with the IME and with the addictions doctor, but the part where, as you enter into a treatment program. And I think I might have been asked about like sort of what my own goals were, but it wasn't asked to me like what returning to work would look like, what normal life outside of the program once it was completed would look like necessarily.
Well, at least you were asked your opinion on a few of those things, because
yeah.
I know it would have been hard for me at that time to maybe articulate in that moment, because it's kind of like you're a little bit thrown off by the whole process. You still can't wrap your head around what's happening really. And then, before you know it, you're kind of out the door and headed to treatment. But if you were given some kind of a heads up, like if you were provided a base point before you went into your IME, or before you went in to talk to a specialist, where you were allowed to, you were given some time to think about, how is your addictive behavior impacting your life? Like a cost benefit analysis, basically.
Yeah. The other thing that would be fascinating to know about, or fascinating to be asked or to track, would be even if there wasn't a return of substance related addictive behaviors or illicit addictive behaviors, if there was an honest assessment of other addictive behaviors that were rising to the surface post treatment, like cell phone use, like screen time, like food addictions or sex addictions, or someone who returned to smoking or now drinks 20 cups of coffee a day, or whatever that may be. Because, as we've talked about, like we are simply trading one strategy for another in some circumstances. And to say that you went through a treatment program for addiction doesn't mean to say that they removed all of your addictive behaviors or put on some ironclad shield so that you will never engage in an addictive behavior again. So it'd be interesting to know if other things are spiking up for people on the other side of a program.
Yeah, for sure. And that's really all we have, right? So I think we're throwing away a tremendous amount of data by not putting the onus on treatment centers to do some kind of a follow-up. It doesn't have to be super expensive, but there's ways that you could do it where, you could offer incentives on it could be the direct cost of treatment. It could be a third party you'd want a third party to do the study anyway. So you would either be government subsidized, whatever. It doesn't matter, as long as you track some of these variables that we could, there's probably tons of little nuanced connections that we're missing and could be very useful to somebody in the beginning. That's just being, even when they do track things like employment, it's never meaningful employment or job satisfaction. Those types of things are not, and I get that they're difficult to track. It would require more work, but it's usually people from lower socioeconomic areas where they're, basically they're at a point where they're either on the street or going to be on the street. And that seems to be where they do most of that type of tracking, where it's a very obvious variable that's really going to affect the individual. But, what about every time a pharmacist, nurse, like when we were both sent, we basically received suboptimal treatment, no matter how you cut it, because the evidence suggests that anything less than 90 days inpatient or out is ineffective, as in it makes no difference in comparison to just not being treated at all. That's what the numbers seem to indicate, right? So at 90 days, you start to get some kind of effect going on. But, a positive thing that could be taken out of that experience for the individual, of course, is that we learn some tools and stuff that maybe will come in, will be helpful later on. But that institute, whatever treatment center you're going to, could be pulling all sorts of studies, and in that time frame, you could get, you should have an intake program that's just dialed right in, right? Looking for certain types of backgrounds, length of drug use, all those things should be recorded in a database, and then there should be maybe even a government stipulation that to operate you need to be tracking this kind of data for X amount of years, that kind of thing.
Don't they want to know that? Like, to me, that seems really important. Like, if I was running an institution like that, I would sure want to know, like, hey, what are the 5-year numbers look like? What do the 10-year numbers look like? I would at least be curious.
Yeah, and that's something that if you look into that, it's actually quite funny how people they've made all sorts of different comparisons with, especially in the like the Minnesota model or the traditional model where you go, it's usually inpatient setting, 12-step based, that kind of thing. In that model, it's a disease. So for all intents and purposes, that's how it's treated. Yet if you put people with so-called drug and alcohol addiction disease, whatever you want to call it, next to somebody with like hypertension or diabetes, the people who go on those medications or go into those treatment protocols are usually monitored, at least somewhat, right? Where they're tracking numbers, they're watching what's effective. We adjust the dose. We look at your lifestyle. We do all these things to try and use every angle we can to give you the best chance of success of hitting a target, right? But in this one, there's not even a real target established other than abstinence, which is not a realistic target. It's not a realistic target based on what we know about whatever this is, disease or not.
Absolutely.
Yeah.
Great question.
Yeah. So it almost, you could look at it, and I think some people do, where it seems like they're not interested in tracking those numbers because it would not look good. I think if the public in general knew how little of an impact I shouldn't say most, but many treatment centers have very little effect on what's going to happen with that individual in the future.
Yeah, it would call into question a lot of aspects of those facilities for sure.
And they're government subsidized, right? Many of them in the States are too. So they're constantly, you can see this effort to put out data to support not just the models that they're using, but the length of stay, right? So you really got to look at that data you got to be careful with what you're accepting as evidence.
I should say so.